Nice to see you all this morning. I'm going to change tack entirely, and there's going to be no contradiction. We're all friends here. I've come into this industry from a completely different perspective to all you guys. I'm not traditionally from a decon background. I'm an ODP by trade, clinical, and I've come from Doncaster and Bassetlaw, DBTH, Foundation, NHS Foundations Trust, to give you a bit of insight to the theatre processes and how that can dovetail into sterile services and decon, and how we can collaborate to help achieve some of the NHS mandated milestones that we do have coming up over the next 10 years and beyond. So it's a different topic to what we've discussed this morning. It's a new group of people for me to bring this conversation to, so I hope that you do learn something, and I hope that we can continue to kind of have these conversations between the decon professionals and the clinical side to maybe help move this agenda forward, because it's been a long time coming. So Doncaster and Bassetlaw teaching hospitals, we serve a population of more than 440,000 across South Yorkshire, North Nottinghamshire and the surrounding areas. We're part of 2 ICS and place organisations, and the stats there for the calendar year, just over 500,000 outpatients, 129,478 inpatients, 208,057 emergency patients, and 4,397 maternity patients. We have 4 hospitals within our region. Doncaster main site is the largest. We have Montague Hospital that evolved from more of a traditional kind of cottage hospital, and Bassetlaw Hospital is based out towards Worksop and incorporates that North Nottinghamshire. We've just done a programme of expansion at Bassetlaw Hospital, so we've now got a large A&E again. We've gone back to taking paediatric patients via the A&E route, whereas for a while we were outsourcing, sending those towards Sheffield. So Bassetlaw is expanding, and the service as a whole is growing to better support our Doncaster region. With regards to sterile services, our average volumes going through our sterile service route, which is outsourced to Steris Parkway, around 13,500 items per month, so that equates to 162,000 volume per year on average. We outsourced 6 years ago on the 12th of May, a date that I'll never forget. That was a busy time. I know that a few faces in here that I know from working on that project back then. The outsource was necessary for a variety of reasons. Doncaster site, the inventory was ageing. It was going to be a huge capital project to keep it in. And for the same reasons as most trusts, it made a lot of sense for us to outsource, and that's what we did 6 years ago. So as I said earlier, I'm a HCPC registered ODP, 20 years plus theatre experience, and I've contract managed this for the last 6 years. I came on as the clinical advisor for a secondment of 6 months, which, yes, has lasted 6 months, has gone into 6 years in contract management. I took the job within estates and facilities with an eye on wanting to expand my education pathway. And so I undertook an MBA at Sheffield Hallam University, and that kind of led me into the sustainability agenda. My dissertation and my kind of study pathway led me into sustainability, and so I look after the clinical sustainability for the Trust. I did spend a fair chunk of time, 6 years, working out of the NHS. I took myself off to New Zealand and worked in this wonderful, clean and green environment. It was an eye-opener for me, coming from the NHS and going into something. The structure of the health system over there is similar to ours. They have a portion of private sector, they have a public sector. It works pretty much like an NHS. But their working practices are very different. Because they have this clean and green image, everybody is quite conscious of wanting to look after the environment. It is part of their working norm. If you say at the end of an operation, are seen to put a piece of foil or a glass ampule into the wrong bin or wrong container, somebody will point their finger and say, Lisa, what are you doing? Like, nudge, get that out of there, put that. Somebody will say something to you. It is their normal practice. Households recycle, people look after the waste. When you're at work, you're expected to bring those values to work. So working within theatre and working within the hospital environment, I realised that we were pretty behind that with cultures and attitudes, and sustainability in the workplace seemed low on the list. However, people do these things at home. I know that I was doing these things at home. I know that my family and my friends all try and look after the waste as people drive electric cars. People are trying to do their bit. So I was curious as to why, when we go through that revolving door and go into the workplace, do we take our minds off what we normally do as part of our values at home? And I was curious about that. So I identified that there was somewhat of a gap between the boardroom ambition, what the NHS wants us to do, what our boardroom have signed up to, the NHS Green Plan, we've all got to do it, and what I was seeing on the front line. And I kind of thought to myself, what is within my influence to change? What's within my umbrella of influence? How can we best tackle this? Well, to me, best tackling something like that would be to combine. Not everybody is a kind of major believer in the green agenda for lots of different reasons. It is a paradox in health. Like, we're sold that single use is best, and a lot of the time single use is best. Like, I remember years and years and years ago when I first started, people manually cleaning laryngeal masks in a sluice and cleaning laryngoscope blades and leaving them to soak for a bit and then giving them a wipe and putting them back on a handle, and you intubate your patient, and thinking that is not the way. So, some of the moving to single use was necessary. I'm not debating that, but I think there's certain things that have a low risk aspect that we could maybe look at going back to how some of the practices used to be to achieve this triple bottom line of carbon savings, potential cost savings, and time savings. So why now? We've got this time frame. So everybody has to look at the emissions that we control directly to reach net zero by 2040, with an ambition to achieve an 80% reduction within the period 2028 to 2032. Now we're 2025 now, we're nearly halfway through, it's not a long time. And we're looking at the emissions that we can influence, our carbon footprint, wanting to reach net zero by 2045 with that 80% between 36 and 39. So within our umbrella of influence, within the jobs that we do, within the jobs that I support and facilitate in my workflow, we are within that Scope 1 direct. We are using the NHS facilities. We are supporting anaesthetics and surgery. The Scope 2 indirect, we use our electricity in everything that we do. And we've also got the blue stream in the middle with the water and the waste and energy use in general. There's lots of parts of our processes that all touch on those Scope 1, 2 and 3 direct and indirect emissions. So there's lots of areas that we can influence. The medical devices there that come in under Scope 3, the food and catering, medicines, everything that supports the patient's journey through our services comes within that. The only thing really that we will struggle to influence is some of that travel outside, so how your patients and your visitors get to the site. Everything else is kind of within our wider hospital reach. So this umbrella of influence, what we did. So within what I can influence and my team can influence, we looked at theatres, clinics, contract providers, waste providers, and procurement. So we identified theatres as priority 1, as it is the most resource-intensive area within a hospital environment. So I came across this example when I was doing my studies, and this blew my mind. One knee replacement procedure creates as much waste to landfill as a household of 4 people creates in 1 week. That's one knee replacement. We do multiple knee replacements in multiple sites, in multiple hospitals, all over the country. So we're creating a Kilimanjaro of waste per day from one type of procedure. And we do multiple types of procedures, multiple specialities, up and down the country, all day, every day. That's what we do. So as part of my dissertation, I had to collect some data. So I conducted a survey amongst theatre staff. And that was where I discovered that 94% of staff wanted to work in a way that was more sustainable. But they lacked the knowledge, motivation, and guidance to be able to do so. There was a psychological model that was becoming popular kind of within the last 18 months as I was looking into this, and it's a model called COM-B. And you take what you think that your staff have said within your data collection, and you categorize it. So there's some things that you can look at and you can say, as a concept, have we got capability? Can we do this? Can we send an astronaut or Katy Perry into space? Yes, we can. We've got capability, we can do it. Have we got opportunity? This is the O in the COM. Opportunity, yes, we have, because it's been mandated. The government wants us to do that. There is a need for us to make those changes. So we've got opportunity, we know that. So then I'm thinking, well, what is it? So that's where the M, the motivation in the COM-B model, it's the motivation that they're lacking. And if you have capability, opportunity, and motivation, then you can achieve that change in behaviour. That's the theory. So we thought, let's look at how much low-risk change we can support to help the emerging culture of wanting change. The Royal College of Surgeons at the time released a powerful document that's kind of become our cornerstone of working with theatre and opening these conversations, which is called the Royal College of Surgeons Green Theatre Checklist. So the first section, anaesthesia, for this conversation we'll leave out, but the section for us that could be appropriate is this preparing for surgery. So we're looking as a trust to work on some of the elements within that section 7 that I'll discuss later on with the switch to reusable textiles. But more important than that really is this intraoperative equipment section. So review and rationalise equipment and surgical items, your surgical trays. So I know from my theatre experience that you go to a surgeon's pick list, we used to call them a surgeon's Bible. You go in the Bible and there are various versions of lists of things that you think that a surgeon might want. And you get them all out and everybody opens them, and then on the day he comes in and he says, oh, I don't want that, I don't want this, I don't want the other. And you've opened things unnecessarily, which creates waste. So there's lots of little things that you can do around this checklist. So surgeon preference list is good. Single-use surgical packs, what can be reused, added to sets, what's surplus. Instrumentation, reducing and avoiding anything unnecessary. Reusables, where possible, or look at replacement of things to lower carbon alternatives. And then after the operation, recycling inappropriate waste streams. So the quick win off there for me that we can definitely have impact into, and that Sterile Services can be an absolute key player in, and that's achieved really good results for that, is tray rationalisation. So we classed it as low risk, but with high impact. We're paying to wash items that are not used. In essence, we're using water, wash capacity, electricity, staff resources. I was trying to explain this to my husband the other day, and he kind of relayed back to me what I'd got across to him, and he said, okay, Lisa, we're going to have potatoes for tea. There's me and you, one large potato each. So I'm going to nip to the farm shop, and I'm going to use my resources to buy a full sack of potatoes, and I'm going to peel and quality check each potato for the little eyes, pick all the eyes out, and I've got a massive pile of potatoes, and we're going to use 2 of them. And then all that work that I've done in peeling, scrubbing, picking the eyes out, we're just going to put them to one side and not bother with them. Is that what you're telling me? I'm like, in essence, yes. Because you have procedures where you open a tray and Mr. Jones takes 2 items off that and then he doesn't use the rest of it. You guys have spent time, significant amounts of time, washing the things, putting them through all the QA, checking all the box joints, checking the tungsten, doing all the quality. Mr. Such-a-Body, who originally requested all these items to go on that tray, has been retired for 10 years. They go through and they go around, they never get used. So that waste was absolutely obvious, and that's something that we wanted to change. But I wanted to sell it to the theatre team as a good idea that was going to benefit them in a specific way. What theatres hate is wasted time. Wasted time is wasted money. Wasted time is potential for more patients to go on that list, increased capacity. So as a scrub nurse, you count your instruments at the start of the case. You then count them at each layer of closure of a cavity. So if you're closing an abdomen, you've got 3 counts at the end. Each count, if you're counting 1 tray with 20 instruments on it, it's not going to take you very long. If you're counting 12 trays with multiple instruments on, it's going to take you a good 5 minutes per count. So if you can reduce the amount of items on that tray, you can go to your theatre team and say, what can we do to make your processes quicker? Well, make your sets smaller, you get time back because your scrub staff are going to take less time to check the trays. So we took that to the teams. We got the staff knowledge of procedures, and we worked closely with the senior theatre leads, clinicians and managers to identify trays and look at what could be safely removed, both instruments and consumables. We promoted the concept of triple bottom line. This triple bottom line is an original economic model that's been adapted for sustainability. The original is 3 Ps, people, planet and profit. However, we looked at saving carbon, saving money and saving time. So you can overlay that information with synergy track data. We used a tray utilisation report and various reports within Synergy Track to identify the trays with the greatest number of items and the greatest usage around the trust, to identify which will give us the biggest gain, what we were going to make the most significant difference with. And then we promoted the teams the opportunity to undertake a challenge, see who can make the biggest savings and who would be able to do these things most successfully. And the teams have really taken it on board. So the results that we got, or the challenges that we got, will we still have what we need? Yes, because you're going to decide what we can take off. We sometimes use this, but only on occasion. Can we have it as a supplementary item? Absolutely. If you still need it on occasion, we'll put it as a sub. Are we supported by companies to remove items from consigned sets, even though we might not use them? Well, we can talk to the companies, we can tell them what we're doing, and we can ask them to take off anything that might not be necessarily used for our surgeons in the way that they do the procedures. And most of them were happy to take the items off, take them back, take them off our consignment, and we just have the smaller sets. So the check sheets and prices were sent to senior staff, including category pricing reduction per set if they dropped the items to reduce the category by 1 or more. We included average usage per set from Synergy Track data to give them an annual savings forecast. We met with the senior staff and consultants, opened the sets, got them to walk the procedure, okay, Mr. Jones, talk to me about how you do this. What do you put your hands on first? What does your scrub nurse pass you first? What do you need? And then, as I said, we contact the companies, arrange set reviews with them. We got the excess removed. And then everything that was removed, we put the CCNs on the system. The staff at Parkway, majority of the time, removes those things for us and then send us them back. And then we've created an inventory of spares, and we've been able to use all those spares, of which there were more probably than we ever expected, to create more trays for other specialities to be used instead of them having to buy new, which has been really useful. And we've tried not to bin anything that might be BR, excess, obsolete, things that we don't use anymore. So we worked with British Medical Auctions and we auction stuff. And we also work with an instrument recycling provider. So the things that have been taken off haven't been binned. So we didn't just remove instruments, we removed 2-ply tissue and ancillary paper items from the sets. Tissue, £8,355 per year we were spending on tissue. As a scrub nurse, it's, I think, a hangover from times gone past where you used to have a gown and your bits and pieces on your tray. We don't do that anymore. We scrub at the sink, we put a gown on, then we approach the tray, we open the tray. So I'm all scrubbed and sterile. The first thing I do when I open that tray is take the tissue off and put it in the bin. Never use it. It was on there from a time when we used to put gowns on the tray with the tissue to dry your hands. Not been done for years, but nobody ever thought to take the tissue off the tray. So I aggregated that £8,355 per year over the 15 years of the contract that we have equals £125,325 on tissue paper that the scrub nurse walks up and goes, don't need that. So it's interesting, the little things that you might not think make a difference really can make a difference. And saving carbon, saving time and saving money, you know, we're all taxpayers. We all want the best service we can get for our money. So we didn't specifically carbon capture the work that we've been doing. Carbon capturing is quite tricky. You have to kind of look at various scientific processes or get somebody to do that work for you. So I looked into other places that had. So Health Innovation, NHS took under similar exercise across a fleet of gallbladder surgical sets. They estimate a carbon saving of 2 to 3 tonnes per year saved on reducing those gallbladder sets. It's interesting, there is less resources we can waste, the more resources we've got for years to come, and you say that the benefits speak for themselves. So the money's here. We'll look at a C-section tray. We were paying £6,034 per month to wash. We reduced, by taking the items off the tray, we reduced it to £4,081.50, saving a massive £1,962 per month, totaling over the year £23,544, based on an average caesarean section rate cross-side modelled on April 2024 figures of £150 per month. So over the last 5 years, we've systematically worked through the inventory and estimated a reduction of 30% on instruments, so tray size, and single-use consumables. Majority have been removed from sets, excepting the waste paper bags. We still have those. And the removed items are packed, made into new trays, used in other areas, or recycled. So other quick win ideas that worked well. We've returned to stainless where possible, replacing plastic bowl, galley pots and kidney dishes with stainless, because there's an argument with stainless. Some people say that stainless is more impactful because of the nature of the mining of the steels, etc. But for us, we felt that the stainless will last a lot longer in terms of years, and if necessary, we can have them refurbished. We invested in more tins to reduce plastic bag waste as part of the returns process. We've moved away from, I don't know what you guys use at your units, but we were given thick brown plastic bags that look like rubble sacks to put trays that needed fast tracking in. So we don't do that now. We just have a sticker on the edge of a standard bag that tells fast track paper sticker. We've removed all trolley liners and delivery notes. We have a tray refurbishment programme, so instead of waiting for things to come towards end of life and needing larger repairs or becoming beyond economical repair, we're trying to refurbish monthly. Lead hands we were finding were becoming frequently damaged, and lead's not great for the environment, so we've moved to a more sustainable product for that. It is marginally more expensive, but I think that they are going to last us longer, so it will pay for itself. We challenge companies on loan kit use to consign sets where possible to reduce transport and logistics of moving sets around from unit to unit, from supplier to sterile service unit, then back to us. These trays do hundreds of miles a year. It's not a good use of the transport. And we've supported teams in identifying the trays only open for 1 or 2 items and secured funding to purchase those items as add-on to the trays or swaps. So a little bit here on another quick win for us was the transport projects. When we first transitioned, we had a van and a man driver. The van was costing us money, and we realised that we could get rid of the van and the driver and look at using existing trust transport to move things around alongside notes, pathology lab samples and other things that would be moved around the trust anyway. So that saved around 4.1 tonnes CO2 per year based on the Transit Connect van mileage that we had. Service users leave trays to be moved across site at a central point for collection. That works really well for us. The only thing is, staff have to be organised and get things there on time to meet the driver, otherwise they miss out. So last big thing kind of that was it within my umbrella of influence was I noticed that theatres were using high-grade clinical waste stream bags, the thick orange bags, for all theatre waste. They don't need to. The only reason they should be doing that is if it's an infected case, infected patient. The alternative we have is a tiger waste stream, which costs 50% more to dispose of the orange. It goes through a chemical treat process as well as incineration. The tiger bag is only incinerated, but we do work with Veolia, which are a energy recovery waste disposal. So the waste, the clinical waste that does go to Veolia, is incinerated in a way that it creates steam. The steam goes into a boiler. The boiler creates heat to power various government buildings in and around Sheffield and the locality. So we've been doing that since January, moved all theatre stream, unless infectious, from orange to tiger, and we've seen an average of 3 tonne reduction per month with an associated cost reduction of 50% per tonne on the figures so far. It's early days because we only started in January, but I'm confident that that will remain. So further projects, Green Theatre focus groups continue to explore ideas and support staff in making changes. We've got lots of engagement going on. We had a Green Champions programme just before COVID that didn't really do very well, so we're relaunching that. We're looking at mandatory education for all staff within our trust on NHS Net Zero, carbon literacy and greener patient care. And we're looking at a return to usable linens where able in theatres and wards, reducing the reliance on single-use caps, gowns, drapes and ancillaries. There will be a budget attached to that, so we are going to have to put a business case together, so bigger work. But if we can demonstrate savings, we might have to invest, but then we will be able to make that cost neutral, and a focus on waste segregation at source to increase recycling. So my take-home message is some of the practical elements are easy to fix. The change maybe your attitudes. The want to change there, certainly within our trust, was reassuring, and little things add up when multiplied over the bigger picture. If we add the economic, time and carbon, we've got that powerful triple bottom line, but we need to help educate into the how and the why to create that motivation. Sustainable practice, I think, needs to be essential for surgery moving forward, not just a nice addition, and it needs to belong to everybody and anyone can start. I think the timing's never going to be perfect, however, we've only got a short time to commit to these changes. And if end to end we can all help each other, we can help you guys. If you're sending less through your system, less resources at your end, less waste at our end, and everything is more efficient. And that's it from me. Thank you very much.